Great. Well, welcome back once again, everybody. Now, I'm not quite sure whether this point in the day is the best time to be thinking about cognitive function, but that's what we're about to do. And our next speaker is Dr. Mark Findlay, who's working with Paddy Mark in Glasgow, who's going to tell us about cognitive function in haemodialysis.
Hello, good afternoon, and thank you to Kidney Research UK for allowing me to present my data to you today. My name is Mark Findlay, and I'm a clinical research fellow working up in Glasgow. I'm going to present the provisional data from a study that I've been doing for the last year. So I'm currently a PhD student with an interest in cerebral vascular disease and stroke in patients with end-stage renal disease. And this project is interested in how haemodialysis affects the cerebrovascular system. So first of all, today I'd like to touch a little bit on the background, the provisional findings of my study, Acumen HD, and you'll see that I shoved that in there when you see the way I made that word together, and then talk about where I'm going to go next for this. So why is this important? Well, chronic kidney disease is an independent risk factor for cerebral vascular disease and stroke. In fact, with increasing age, your risk of stroke increases, and with each increment in CKD to the point of dialysis, the risk of stroke gets higher and higher. So much so that the incidence of stroke in dialysis patients has been reported as being up to 10 times higher when compared to the general population. Allied to this, cognitive impairment is a very significant problem on kidney patients as well, so much that for every 10 mil loss in GFR, there's an 11% increase in the prevalence of cognitive impairment. And these have been shown, cerebral vascular disease and cognitive impairment, to be correlated, such that we believe a degree of the cognitive impairment in dialysis patients is caused by vascular disease. But this begins even before the dialysis process. A UK study looked at the low clearance cohort and showed that roughly 1 in 5 patients had some degree of cognitive impairment. And in dialysis patients, this can be reported as as high as 70% of dialysis patients had cognitive impairment. And what's worse is that of that particular cohort, only 3% of them were recognised as having cognitive impairment prior to this study, suggesting that not only is it common, but it's under-recognised. But does it really matter? Well, cognitive impairment in itself is a risk factor for mortality in 2 papers, one from the UK, one from the US, looking at mortality in dialysis patients. And more recently, the Scottish Registry has released a paper that ties in cognitive impairment as an association with dialysis withdrawals, a reason for clinicians or patients to stop treatment. So from a clinician side of things, that's important. Recognition of cognitive impairment is important because it carries a mortality risk, but from a patient perspective, does dialysis really have an impact? One patient in my studies described what she called dialysis mush, a feeling of mushiness after dialysis. She feels she can't quite concentrate. And this isn't new, this isn't unique to her. People have described this before. There's a beautiful article from the BMJ back in 2012 written by Nicholas Evans, the author of The Horse Whisperer, where he described very beautifully that life on haemodialysis is a grueling business. Dialysis blurs the mind, making it hard to concentrate. He hoped that he'd be able to finish his novels when on dialysis, but found that this was not possible. So how does dialysis affect the brain and the cerebral circulation? Well, this has been shown before, as far back as 1994, using a method known as transcranial Doppler and ultrasound, where we scan the temples of patients to monitor the mean flow velocity, which correlates to cerebral blood flow, and shows that before and after dialysis, there is a decline in cerebral blood flow, which correlates to the volume of ultrafiltration taken off and seems more marked in diabetics. However, nobody's ever looked to see if this actually has any clinical impact. We all know that blood pressure decreases after dialysis. It would make sense that cerebral blood flow could change as well, but doesn't matter. And what happens to the brain in patients with chronic kidney disease and dialysis? In patients in dialysis with no history of cerebral vascular disease, it's found that white matter hyperintensities and MRI-based finding of early ischemic brain changes are incident as high as 50%. Half of dialysis patients will have these compared to 20% of a healthy matched population. In addition, atrophy is far more common. Now, atrophy is shrinkage of your brain, a feature of aging, particularly frontal atrophy. Frontal atrophy happens first, and it's rare in patients younger than the age of 55. And yet in a study following up over 3 years, they could see a significant decline in frontal atrophy in hemodialysis patients with a mean age of 56. So a young cohort showing evidence of brain atrophy. And that same group showed in a further paper that this appeared to be linked to ischemic changes, suggesting that, again, ischemia is causing the brain to shrink. But does it actually affect your cognition? Has this ever been shown? Yes, this has been shown in a couple of different studies with slightly variable outputs. I've chosen this particular study because it fits quite nicely with my talk. What this has shown is that with the dialysis cycle, patients tend to have a decline in global cognitive function during dialysis that recovers as they get off dialysis. Now, it would be dangerous to stand here and say, clearly this is all dialysis related, it must be to do with blood flow. This is a multifactorial process. Patients with chronic kidney disease have more than just dialysis going on. Patients on dialysis have more than just dialysis. There's drugs, there's toxins, there's things present in the water, although not so much now. But what has been taken interest by doctors looking at cognitive function is executive function. Executive function, the ability to plan and carry out complex tasks, I'll show you an example of that later on, is thought to be a marker of vascular pathology, and that's gained great interest in dialysis patients. So what have I been doing with my time for the last while? Well, I've been running the study known as the Acumen HD study, and you can see I've squeezed it in there, assessing cognitive function and measuring the cerebral circulation on haemodialysis. And what I've been doing, I've taken Glasgow patients who are on haemodialysis, so real patients. I've ruled out anybody who's had a stroke, or if they've had imaging for whatever reason, if they have evidence of small vessel disease, lacunae, anything on their brain imaging, they're ruled out. I've also asked anybody who has cognitive impairment not to be involved. And then I've recruited blindly from an age group of 18 to 85-year-olds, asking them to take part in this study. There are 2 visits, which is what I'm presenting today, and then a 12-month follow-up. 2 visits again. The first 2 visits consist of a dialysis-based visit and a non-dialysis-based visit. For the dialysis visit, I go and meet patients at their usual dialysis unit when they're getting their usual dialysis. I arrive with my little machine, which is this one here. It's a transcranial Doppler machine, and that's me wearing the lovely headset. And I ask patients to put this headset on. And this holds these 2 little probes in place which scan through your temples using an ultrasound to measure how fast the blood flow is going through your brain, your middle cerebral arteries. We do that before dialysis, and we leave it on during dialysis and do another measuring again at the end. And I map out how the blood flow changes or is altered. I also, on the same dialysis session, work our way through this neurocognitive assessment covering multiple domains, which I'll talk about in the next few slides, of cognitive function. And in a select cohort, I've stuck a few in the MRI scanner, and I'm not going to touch on that data today, but that's future work. And as I say, I then asked to meet them again on another time, but on a non-dialysis day, and we repeat the neurocognitive assessment. This gives us a score on the machine and a score off the machine. What does the cognitive assessment consist of? There are multiple tools used within this, and it lasts about 45 minutes to an hour. The first test is the MOCA, which is a standardized screening tool useful for detecting of vascular markers such as vascular dementia. Replace the MMSE because it's free, and it covers multiple different domains from executive function, memory, language, mathematics. This is a useful assessment as it has a clear cutoff for which cognitive impairment can be defined. Another test, a test of language, a test of frontal lobe function, where patients are asked to name as many words as they can in a minute, beginning with certain letters, F, A, and S, or as many animals as they can in 1 minute. And a test of executive function, the ability to plan and carry out complex tasks. Patients are asked to join the dots. There's 2 versions, a trail making A and a trail making B. This is the B. Patients are asked to join 1 to the letter A, then the next number to letter B, C, and so on. And we're timing them to see how quickly they can complete this task during a dialysis session. And finally, a test of memory, using a test known as HVLT. I read out this big long list of words to patients, and I ask them to repeat them back to me. We do this 3 times, I give them no warning, and 20 minutes later I say, can you remember any of those words? And see how long they've retained the words for. So that's what we do. So the demographics, well, what does my patient cohort look like? So as I say, this is early data. There are a few more patients to add into this, but this is essentially the message stays the same. I have 70 patients who have completed both visits so far. And the mean age, and that's probably the most exciting thing about this slide, is 58 years old. Now, the average age of starting dialysis in Scotland is 65, so this is a very young cohort. Slightly worrying that this may be underrepresentative, but this is who was willing to take part in my study. Question 1. How common is occult cognitive impairment? So remember, this is a group of patients who are not thought to have cerebral vascular disease and not thought to have memory problems, and yet using established MOCA cutoffs of cognitive impairment, I found a huge proportion of cognitive impairment. Up to 60% of these patients had some sort of demonstrable effect of cognitive impairment. Now, I'm not sure that's necessarily the case because it didn't seem to be fair for the cohort I was asking, so I used a slightly different criteria that's been used in previous papers. This uses the Mayo criteria for mild cognitive impairment and the DSM-4 criteria for dementia. You can see that the details as to how I stratified people into mild, moderate, and severe cognitive impairments at the bottom, but I think this is probably more representative. But either way, no matter how you cut it, there appears to be about 50% of these patients have some form of cognitive impairment. So which factors could influence cognitive impairment? So based purely on demographics, it's quite interesting using the MoCA cutoff to see that patients with cognitive impairment, on average, had larger volumes of fluid taken off on dialysis and had lower URRs, lower clearances, how good your dialysis is, although neither of which were particularly extreme. The URRs are still well above the expected national targets, and the UF volumes are not particularly high, but there was a trend towards this. And this is my data looking at, does dialysis change the cerebral blood flow in our patients? And again, I was very reassured to see that yes, it does. We can see, using this graph, which shows you just before dialysis, a few readings during dialysis, and again, one up to half an hour at the end of dialysis. This is when they're no longer being dialyzed. The cerebral blood flow decreases significantly and stays down for up to half an hour after dialysis. This is correlated strongly with the UF volume and weakly so with the blood pressure. Most of us will recognise that the weight change is essentially the same as the UF volume, but the amount of fluid taken off seems to change the cerebral blood flow. Are there any measurable differences in their cognitive test? Are they worse on the machine or off the machine? And interestingly, we can see that patients on the machine, and I'll explain the numbers for you, tend to be worse at certain tests on the machine. So during dialysis, people name less words per minute. They're unable to perform a test, which I haven't talked about, but this is a test of processing speed. And they score worse on the trail-making test than they do off the machine. The numbers look slightly different here. They're lower here and higher here because this is number of points scored, whereas higher here and lower here, but this is time taken to complete tests. So it is slightly different, but believe me that they are worse. I can't quite explain why patients tend to have slightly better memory when they're on the machine compared to off the machine. But that seems to exist so far. And the crux of the matter, does it have any correlation with change in the blood flow? And I was very excited when these results came through, showing that as patients' blood flow decline on dialysis, it appears to show a decline in executive function, which is measurable, suggesting that hemodialysis possibly is, through some cerebrovascular mechanism, impairing cognitive function. So to summarise, cognitive impairment is common in those with end-stage renal disease and poorly recognised. Hemodialysis induces a transient cognitive decline in tests of frontal lobe and executive function, and there is a correlation between change in blood flow and change in cognitive assessments. So where do I go next from this? Well, as I say, these are provisional results. There is more ongoing, and this is halfway through the study, essentially. So 97 have been enrolled. There are a few more added into this. The message doesn't change. I was very reassured to see that that was the case. I just wanted this to be in at the abstract deadline, which will hire slightly short of a few patients. I'm now at the point of following patients up for 12 months, and what I'm interested in is, are those who decline on dialysis, do they have worse cognitive function 12 months down the line? Are they aging faster from a cognition side of things? I also have my MRI data, which I'm adding in, and again, I'm interested more in the change over 12 months. Are the dippers, the blood flow dippers on dialysis, showing more small vessel disease change on MRI 12 months down the line? And I've also added an assessment of frailty because we know that this is a tie-in. So there's another spin that will come from this study, which is not important to today's talk, but just to say that this is out there. Obviously, I have a few thank yous to make. I'd like to thank both my supervisors, my stroke supervisor, Dr. Patrick Mark, and my, renal supervisor, Dr. Patrick Mark, and stroke supervisor, Dr. Jess Dawson. The nurses who have been helping me out, all dialysis units who have been extremely patient with me, saying, don't put him on yet, don't put him on, I had to scan his head. And all my willing victims or participants, depending how you look at it. Very pleased that they're willing to wear this headset. They mostly want the curtains round or sometimes in a side room, but they think this headset is very funny. They describe it as a miner's hat, but one lady described it as that hat that Doc wears from Back to the Future. Didn't think it was a good change for dialysis, but who knows? Any questions?
Very much. Some of those tests look quite difficult to me. So, questions? Yeah.
Following a recent high-profile legal case, actually in the west of Scotland, Lanarkshire, a huge amount of work is now being done in the context of appropriate consent for transplant and trying to explain to patients, these patients, dialysis patients, about the complexities of extended criteria donors and the impact on outcome, etc. How can we possibly expect our patients to grasp these concepts in the context of the data that you are presenting?
I think that's a very good point, actually, and I think a lot of this work has come from the background of Anne Murray from Massachusetts. She's done a lot of work and she's come to some very good conclusions, one of which is we shouldn't be speaking to dialysis patients on dialysis because there seems to be effects that we can't adjust for, and also if there's so much occult cognitive impairment, should we really be expecting these patients to understand the complexity? And you're right, and I don't know what the answer to that is. We wouldn't deny them transplants because we know that that's a treatment for improving cognitive function, for improving the stroke risk. So denying them that would be unfair. But I suspect the same is true in Edinburgh. We don't routinely assess cognitive function pre-transplant. We don't even do a MOCA. Perhaps we should. Perhaps this would give us some sort of insight as to their likelihood to cope with the stresses of steroids, complex medication that we're about to give them. It's work in progress.
Just being devil's advocate, did you do the tests in reverse? So you found that, was it actually the dialysis test first and then you did a non-dialysis day, or did you reverse it?
For the bulk,
and also, did you have, they're distracted because they've got a fistula which they can't move, so their attention span may be affected by that. Can you control for that in your reassessment on a non-dialysis day?
Yeah, no, very good questions. For the bulk of the patients, unfortunately, the way I'd written the protocol, they were assessed on dialysis first, but there is 20 of these patients who were assessed on a non-dialysis day, and it doesn't change the outcomes of the correlation, which I think is the key new finding in the study. With regards to the distraction, you're absolutely right. If you're stuck with needles in your arm, frightened to move it, patients are asked to try and mimic how they sit. They're brought back to the dialysis unit rather than to a research unit. And in fact, one of the units has been really good at wheeling in a machine, switching on and making it beep an alarm in the room with them. So the simulated dialysis session to try and overcome the distractions of this dialysis unit compared to what might happen in an office, for example.
Do you have to take into account the 2 and 3 day gap, or do you always do it one day after?
We've purposely avoided the 2-day gap in all patients. Not that there's any evidence that works, but my assumption was always at the start of this maybe related to UF, and if so, they're going to get the biggest volume on Monday or Tuesday. So no patients are seen on the Monday, Tuesday, and their repeat non-dialysis visit happens at the end of the week as well, so day after dialysis.
Do you think there'd be any benefit in doing the assessment and the measurements during a sham haemodialysis?
Somebody asked that. I think yes, because there's always a fear of these sorts of studies. It's a little bit the same with when we prescribe ACE inhibitors to patients with CKD and they have one episode of diarrhea and develop AKI, they're never touching that drug again because it's bad for them. If patients start hearing that dialysis causes memory problems on dialysis, patients might get frightened and put off it. Possibly not because it's life-saving, but if we come to those sorts of conclusions without something like a sham study, then it could have serious impact.
Sorry, what was the volume of UF between the two cohorts?
Yeah, it was not huge, but it was something like 1.8 and 2.1 litres. So it wasn't a huge difference, considering that it still is about 2 litres.